do speak, to remute your line so we don't get background noise during the meeting. We'd appreciate it if everyone can change their video settings so we can view you and the speakers participating in the meeting by going on video settings and click on the item that says you can display all 49 members at one time. That way you can see the entire panel. Next slide, please. I am Tina Hernandez-Broussard. I am the chair of the NAC. This will be my last meeting I'm chairing, so welcome. Next slide, please. If a non-NAC member would like to make a comment during today's meeting, please send an email no later than 12 noon Eastern Standard Time. 12 noon, is that Eastern Standard Time, Jamie? That can't be 12 noon Eastern Standard Time. 12 noon?
Sorry, Eastern Standard Time.
Okay, 12 noon Eastern Standard Time to National Advisory Council at ahrq.hhs.gov. And your comments should be limited to 3 minutes. Next slide, please. So some NAC member updates. Chelsea Richards is retired in October. His replacement is Liana Arias, who is the Deputy Director for the Public Health Science and Surveillance at the CDC. Also, sadly to say, it is the last meeting for Karen, Kathy, Bethan, myself, Charles or Chip Khan, and Andrew Miska. So we will be rotating off this session. So this will be our last session. Okay, for the first order of business, I would like to ask for any changes or edits to draft from the previous meeting from July 14th, 2020. Any changes or edits to the draft of the minutes from the meeting? If not, I would like a motion to approve the minutes.
This is Greg. A motion to approve.
And a second?
Second.
Thank you. So please sign and mail electronic copy to Jamie once you get a chance to do that. So our next order of business, I would like to introduce, let's see, so Gopal Khanna will not be joining us this morning. And so in his place, I believe David Myers will be up next and talking about AHRQ's recent accomplishments for research practice improvement and data and analytics.
Thank you so much, Tina. And thank you all to the NAC members for joining us. Can we get the next slide? I'd love to show Gopal's picture. Mr. Khanna, unfortunately, is suddenly not feeling well and is taking himself to get medical care this morning. And so he wrote me early in the morning, expressed his deep disappointment that he wouldn't be able to be here today, and asked that I share with you the remarks that he had prepared. So this is his voice, his words, that I'm honored to be able to share with you all today. And I apologize, I am reading and not looking at you, but you understand why. Good morning. Thank you to all of the NAC members and to the AHRQ staff that are in attendance. It is once again my honor and privilege to welcome you to the National Advisory Council. Before we move forward, turning it over to my colleagues Lucy Levine and David Myers for the rest of the AHRQ update. As most of you can imagine, today's meeting is extremely important, not only because it is the last of the year, but it comes as the United States heads into a winter with new record highs of COVID-19 cases. It also comes as AHRQ prepares to address upcoming transition issues, which I plan to assist throughout the process. Our staff has worked tirelessly over the past few weeks to put together a transition package for the department that demonstrates the tremendous value AHRQ brings to the HHS family, especially through our work to address the COVID-19 pandemic. We've had great success contributing to Secretary Alex Azar's whole of government COVID-19 efforts, in large part due to the coronavirus strike team here at AHRQ, as well as our rapid response team. Through these two efforts, we have provided analysis and expertise to aid the department in our response efforts, and we helped to launch the AHRQ National Nursing Home COVID-19 Action Network, which you'll be hearing about a little later today. Today also marks the last meeting with Tina as our chair, as well as the last day of our colleagues Karen Amstoltz, Kathy Bradley, Beth Ann Dougherty, Chip Kahn, and Andrew Massica. And this is Gopal again. Thank you all for your service to NAC and to AHRQ, and I add mine as well. Tina, I want to thank you personally for everything you have done to raise the profile of our NAC and to help carry the message of our 21st Century Care Initiative. Your leadership has set a new standard for NAC member involvement moving forward. As some of you may know, Tina recently began co-authoring a forthcoming blog on telehealth safety and quality with Armando, Peter, and Karen. We are extremely grateful for this new type of participation by our NAC members as blogs become a new and regular form of participation for the NAC. If any of you are interested in contributing an AHRQ Views blog, please contact Jamie for more information. One of the reasons I'm so proud to have Tina and others co-authoring this blog is that to me, it represents a greater paradigm shift at AHRQ. Since becoming director of AHRQ in May 2017, I've made it a goal to change the way we communicate and think, to do a better job of understanding the needs of our stakeholder and the perspective of health system leaders. We have so much to offer in the name of healthcare safety, quality, and value, and I firmly believe that changing the way we communicate our work will significantly increase our impact. This belief is one of the driving forces of my focus on AHRQ's 21st Century Care Initiative, which I first discussed with you in 2018. At its core, 21st Century Care is a rallying cry for healthcare experts and researchers to come together under one central theme of dramatically improving the quality, safety, and value of healthcare services in the United States. You've heard me talk about 21st Century Care in the past, and your feedback has helped shape our thinking on this subject. You've heard me say over and over that we need to take a step back and think differently about our work and about health services research as a whole. As you've heard me say, cure and care are two sides of the same coin. A few years ago, Congressman Diana DeGette and Fred Upton, as well as Senators Patty Murray and Lamar Alexander, gave us the 21st Century Cures Act to bring America 21st century medicine. It's my belief that the next frontier is to bring the American people 21st century care. At the end of the day, 21st century care must take the best and brightest ideas from healthcare experts, frontline clinicians, industry leaders across the country, and translate these ideas into research, into evidence, into best practices, and into rapid cycle, easily implemented, scalable, and effective work. Each of you has a role to play in making this a reality. So today, I'm hoping to solidify a commitment from each of you to help carry this message moving forward. COVID-19 has thrust the quality of healthcare in the United States into the spotlight and is fundamentally changing the way healthcare will be delivered in the future. We must be forward-thinking in our approach, anticipate emerging needs, and take action. As we think about 21st century care, I would urge you to be expansive in your thinking, to think of what more AHRQ can do and the bold ideas we can pursue together to address the many issues that have emerged from COVID-19. With that, I want to turn it over to Lucy to provide a budget update, and then to David for the director's update. Once again, thank you to each of you for your hard work and commitment. Let's make today's MAC meeting one of the best ever. Lucy, over to you.
Next slide, Jen.
Thanks.
Next slide, Jen.
Absolutely.
Next slide. Good morning. We haven't had a huge change, although a lot is going to happen today, I believe. As you know, when we last spoke, the House Appropriations Subcommittee had recommended $343 million for AHRQ in 2021. That is a $5 million increase over 2020 and an $86 million increase over the 21 president's budget. The Senate, this next slide, the Senate subcommittee has not yet provided their allocation. Well, frankly, it's expected they will today. I don't have any details yet, but Senate Appropriations Chair Richard Shelby will unveil the text and committee reports for about a dozen 21 spending bills. Sorry. The expectation is that Congress wants to pass a massive omnibus, and this package hopefully will prevent the shutdown that will happen at the end of the continuing resolution on December 11th. I will tell you, however, that I don't expect the Senate number to be that high. Like last year, the Senate subcommittee went with our president's budget level. We ended up doing fine, so don't be concerned if that happens. But it'll be an easy starting point for them. It allows them not to just take the president's budget recommendation and start negotiations. So I don't have any details, but check your email often today. I have a feeling the numbers in the text will be coming soon. And as I said, we're currently on a CR. It goes through December 11th. We operate on a daily rate. Everything's fine. We're moving forward, funding grants, doing our work. And hopefully we will have an omnibus beforehand or another CR until an omnibus can be passed. This is clearly an old slide because another possible COVID-related supplemental does not look like it's going to happen anytime soon. I would wait on that for a while. And David, that's the update. Happy to answer questions.
Thank you, Lucy. And so NAC members, if you'd like to ask anything about AHRQ, what we're doing, and specifically around our budget and the future of our budget, this is a great time for us to share that. So either put it in the chat or come off mute. Wave your hands. Okay.
So this is Melinda. Is there a, you're not optimistic about the COVID-related supplemental, but are there funds for AHRQ in that bill or any version of that bill? I know it's a moving target.
It's hard to say. We have proposed a lot of wonderful initiatives and work. It depends on the moving target of what's in and out and what they think can get passed. So really, the answer is I have no idea. Sometimes we're in, sometimes we're out. And honestly, I don't know what would actually get passed to go forward in the two bodies. So it's uncertain. And I
telling us about the wonderful things that you did propose and would like to see in there.
We'll have a section to follow up on that. So
Okay.
Let's do that during our COVID section. We'll tell you. But also, Melinda, just so you know, and everybody knows, AHRQ did not receive any direct funding from Congress during the first 3 COVID-related supplemental bills. We have received funding from the department, which we'll talk about a little later, to do some very important work, as well as we used appropriated funds, and we'll show you that. Tina, would you like to call in folks?
Yeah. And so do we have any questions for either David or Lucy? You can please remember to send your questions to the panel and just let us know you have a question. Anything else? Otherwise, we can move.
Okay.
Okay.
So
all right, great. So moving on, we can, we'll move on to our next agenda item. And so this is again, David and Mamatha. So I would like to, Dave.
I think it's actually, Tina, I think it's actually still me. Next slide, please.
Yep, it is. It's just next slide. Yep.
Yeah.
Oh,
So
sorry.
It's quite all right. It's quite all right.
I was like, you were really quick right now. I
we're so far ahead. Yeah.
Sorry about that.
No, please don't be. And for our NAC members, thank you again for the opportunity to share with you some of the really exciting work that my colleagues all around the agency have been doing. And those of you who've been around for a while know that what we try to do here is just give you little tastes. We're running you down the buffet. There is no way for you to get a full meal of what AHRQ is doing. We just don't have time for that. So we had the hard job of selecting just a few examples from the different areas, next slide, of work that AHRQ does. So we're going to give you some examples of what we've done just since we last met in health systems research, practice improvement, data and analytics. And then a final thing, we're really committed to being the most effective and efficient and happy workplace, a place good to work as we can as well. And so we're always happy to share those with you. If you have at any point other questions about what AHRQ is doing, we are here for you throughout the year. We don't just have to use these our NAC meetings to teach you about what we're doing. This year, or for this month, the teams around AHRQ, I think, decided to throw me the hardest curveballs they could to make it really difficult for me to sum up all of the work we're doing. So I apologize in advance, and I'm very glad that many of them are here on the phone, on the line, to answer questions that you may have about their work. Next slide, please. So let's start with health systems research. Next slide. One example that really puts together a lot of work is a report that was put out by our team in the Division of Digital Health Research. Now that is a new division for AHRQ. It is the built out of the our Division of Health Information Technology. And we, over the past year, went through a process and expanded how this team is thinking about what they're doing more holistically. If you have a chance, I highly recommend early in this report, the strategic vision, their framework for that, how they think about digital health research, both the research component of it and the implementation of it. Annual reports are not something I normally put here. They're normally dry and dull and only for the really, really intensive needs. This one is different. This team did just a lovely job of explaining why they do, what they do, sharing the importance you can see here about patient-centered care, about how they're working with health systems to improve care and building a better digital ecosystem for the future. And finally, at the end, so not only do they talk about important work that their grantees did and how that work is actually being implemented, they also did a focus on digital clinical decision support as well as patient-reported outcomes too. So they have deep dives on these important topics. So I highly recommend this report to you that really shows what health services research can do to improve healthcare. Next slide, please. AHRQ for many years has received, I'm sorry, many is too strong a word, but for the last several years has received money directly from Congress in our budget to do research to help address the opioids crisis. And we don't get a lot of money to do that. So we have to be very, very focused. And the team this year recognized an important gap. And instead of looking, so several years ago, you may remember we did work to help rural primary care physicians increase the prescribing of medication-assisted treatment, really important program that is still showing results. But this year they moved on to a different area of need, which is recognizing that it's not all about illicit use, that some of our problems with opioids is overuse, especially in vulnerable populations, such as older adults. And that there's a twin problem of appropriate pain management and avoiding inappropriate opioid use. So a series of grants awarded this year that are looking at how do we both manage pain and do it safely in older adults. And you can see 3 really interesting grants that we gave, but also how the team is really seeing these as a whole, is bringing these researchers together, and they are already planning to present jointly on their work, even though it's just getting started. So stay tuned for more on that. Next slide. Final thing on research actually could have been, and I wanted to put this in practice improvement, but then I realized there, because it's about the future of patient safety, it's really a cross-cutting thing. This is about data, about improvement, and about research. Our very own Jeff Brady helped represent AHRQ as the co-chair of the National Steering Committee on Patient Safety that brought together 27 organizations to think collectively about the future of the nation and our work in safety. And it's a fabulous report, defines 4 areas of work, which you can see at the bottom of the slide, has companion documents that are about implementing this. But one of the things that this report does, it begins to lay a framework for a future patient safety research agenda. And AHRQ is convening meetings this fall to really help us, bring people together and ask, given this report and this communally decided framework of where we need to go, where are the big research gaps and how AHRQ can play a role. So I'm excited both for the report, for the effort of our team to make it come to fruition, but also the sort of diving board, the platform it gives us to move forward in our safety work, our safety research work. Next slide. Let's move on to practice improvement. That's a nice segue, actually, because there are also many things, tools that will need to be developed. Next slide. So one of them, again, from our safety program, not out of the report, but AHRQ has been, one of our crown jewels has been the CUSP program, Comprehensive Unit-Based Safety Program. And the team has continued to expand what we do from the hospital. This is a program that's moved it into long-term care facilities, and also bringing our work in antibiotic resistance and the importance of antibiotic use and antibiotic stewardship. And so bringing together CUSP, working in a new domain, bringing in this other important aspect, this program has put together a set of tools, evidence-based tools, to really help clinicians and systems, not just physicians, but nurses as well, think together about how collectively they can make a difference in antibiotic prescribing. And a lot of this has to do with the overprescribing of quinolone antibiotics, which themselves have side effects, but also lead to antibiotic resistance. And they've made significant differences using this program and really changing practice. Lots to learn there. Next slide. Flipping back to the combination of patient safety and digital health, here's a great example of a series of reports that are coming out, moving in an area that we've put as one of our areas moving forward in patient safety, which is improving diagnosis, and a report focusing on telediagnosis in our new age and how healthcare is being delivered. We are all very excited to see what the nation was able to do in telehealth, but it also brings up questions of safety. And specifically, this report looks at when initial diagnoses have to be made using telemedicine, how can we make sure, when is it appropriate to do this? When do we need additional tests? What other things can be done in telehealth to improve the accurate diagnosis through telehealth? So it also then shows people potential pitfalls and again lays out areas for research. Next slide. Let's go, yep, and let's, thank you. Here we go. Data and analysis. Some of you I know get very excited by this. I certainly do. Our team has been very busy in many areas. This is also is an example also of how we're improving using new ways of showing what data says, but you can look at these maps. The one on the upper left is for young adults and children. Then we have on the upper right, adults and then seniors in the bottom, and red is what you don't want to be. And so if we think about suicide in America, it's often, and it was historically thought to be something of older white men who are at the highest risk. And what we've been seeing is that in hospitalizations, this data shows the epidemic of suicide is changing. It's moving to younger and younger age groups. Many states in the country now, the most likely people to be hospitalized or seen in emergency rooms for suicide attempts or ideation are actually children, sometimes under the age of 10. But also in middle-aged adults as well. This data is now slightly old. We'll have to see how America is dealing today, but it's just a good reminder of how data can show us where problems are that we might think we know, and they show us that there is more to learn. Next slide. A second slide of how that touches on how AHRQ is trying to use data to create predictive analytics to help healthcare systems and policymakers understand what might happen in the future. And this is around using what has happened in past hurricanes to help us understand how to prepare for future hurricanes. This is ER use of people age 65 or over in the week following a hurricane. And it is not surprising to see that injuries fly up during, immediately after a hurricane. What may be surprising to some people is that the largest increase, other than injuries, was actually in respiratory conditions, and then also this very large bump in circulatory conditions. So it gets us thinking that after an emergency, it's not just that immediate injuries, but that the capacity of hospitals to deal with asthma and COPD, as well as heart attacks and other respiratory, circulatory conditions, also have to be bolstered. So data that we can use to make better decisions. Next slide. One more. This is just a reminder that we continue throughout to build on the work of MEPS. This is the insurance component chart book, which was just released in the past few weeks. It's what lets us say as a nation, how much are we spending, how much are families and individuals spending on healthcare? And one part of that MEPS work looks at private insurance. And this is just one example that you can find in the chart book of how the cost of employer-based insurance has changed over time. And you can see while in the family or the individual level increased a little bit, I think that's about 3%, 3 to 4%, the family plan increased to much more than that, 6 to 7%. Next slide. Two more. We are in the process of releasing the 2019 National Healthcare Quality and Disparities Report. It is now a single report. These are some examples, recent examples on the left, recognizing that home healthcare providers, that's an important part of the report that you can see, that families, patients who come from the Hispanic community, the Asian community, and specifically the American Indian community report not feeling respected when they're being treated in their home. So an important area of disparities for us to consider. On the right, and this is also, I think, an example of how we're trying to move to infographics and, again, ways of showing our data better. If you look at the three circles, the red one is by far the largest, and that represents death and overdoses from synthetic opioid use, so non-methadone related changes. And the, what is this, 18-fold increase in death rates over the mid part of the 20-teens in the African-American community. Next slide. And finally, one more, last slide. There were many other things, and I'm sorry we didn't get one together to tell you about the work that AHRQ did on telework and the amazing things our team in the Office of Management Services did for us in moving us online as an agency and then checking in with our staff and our managers and figuring out how do we do this, how do we keep it working, how do we do it better, and how do we prepare after the pandemic to use telework effectively. That was one area of operational excellence. Another is our Office of Communications, who have continued to excel. You can see here large increases in the number of people following our social media accounts. The number of impressions continues to go up. If people don't know what we're doing, they can't use the knowledge. So real big thanks to them as well. I think that's my last slide. Next, does it say questions? Yeah. So happy to go back to any of those. We have the experts here. I think I saw a question saying, can you get the links? Absolutely, NEC members will get these slides as well as the links to all of these tools.
Great, thank you, David. So now we'll open it up to questions. Please send a comment in the chat box if you have a question, and we already have some coming in. So we'll start with Armando. Armando, do you want to unmute yourself and ask your question?
Yeah, it was quick, Tina. So Dave, I was just wondering on the insurance slide, because it looks like it was tracking from 2006, I believe, up until more recently. I just wanted to know if it was inflation adjusted.
I absolutely believe it was, but I have a feeling there's some people from CFACT on the phone. Joel, are you here to confirm? Armando, we'll get you that before the end of the day. But yes, okay. I believe those numbers are in 2017 dollars.
Gotcha. Okay.
Great. We have another question from Yanling.
Yes, thank you, Tina. And I have a question on these slides number 22 is about healthcare quality and equity. And I'm intrigued about this differences of the different ethnic group about receiving courtesy and respect. And Asian and Pacific Highlanders is at the bottom. I'm just curious, do we know what is the factors behind this big 10% difference in it?
So Yangling, it's the perfect question, and that's what we do at AHRQ. And we're actually, our teams, both from our quality and disparity report. So actually, I'll step back. One thing they like to do in the report is not only show the statistics, but they actually give, if you go and read the reports, resources for health systems to use to address any of the issues in the quality and disparities report. So yes, often we have tools already available to help people understand more about the issue or how to address it. This is an area where I think we know less, but AHRQ is pulling together with our Office of Priority Populations and our group from the quality report to think about what is AHRQ's role in, and I think this is happening across HHS and across the larger health system, but what are the needed things to address disparities, create equity, address systemic problems within the system as well. So we will be bringing that to you in the future. But if Jeff or anybody else on the team from AHRQ have specific things about, do we know why certain groups are reporting feeling less respected when receiving home care? I actually don't know. So there, if we have tools or actually have done work already to understand that disparity.
I wonder if it's because the language issue or because the culture competency plays some role in their communication with people with a different culture background.
And I know we have Susan on our NAC right now, who her work with the CAP survey has helped to explain different cultural starting points that people start with and how they rate things. So some of this could be different expectations. I think you're right. You brought up language as another thing. I was most struck by that while often Asian survey respondents report lower quality just systematically, American Indian is different. There is something, and it is by far the worst in that. So what else is happening? There, I think more. I apologize. Are there, Jeff and team, any, I don't know if Karen Chavez is with us, the leader of that work, or?
David, this is Susan. Just quickly, when I saw that, I wondered, I don't know what the time frame is for when the data was collected, but I know that during the COVID pandemic, there have been enormous challenges for home health service providers and patients who are very, very concerned about how safe it is to let someone come into your home who you know is going into other homes. And so I'm wondering if there's anything about the use of PPE or cleanliness, you know, not their personal, but just the protective things that people need to do that may be at play there. I don't know.
That is a great reminder for us and insight, Susan. I'm pretty sure this data is older.
Yeah.
It's pre-pandemic. In fact, I think that slide is from our 2018 report, so it's data collected in 2017.
Yeah.
But so we will look for those changes as well.
Well, I think then I would go back to what Yan-Ling said more about the cultural competence and the differences between the people receiving the care and the people delivering it and how they understand things.
Yep. All good things.
So we have one more question from Peter regarding the data. We'll take that one and then we'll move on.
Thank you. Thanks, David. Great summary. And as you say, there's so much going on. It's thank you for summarizing so much of that. I did have a question. Clearly, the focus, at least in some of what you presented, is on the data that AHRQ has in terms of MEPS and the like, and HCUPs and being able to leverage that. I know there's a lot, we all know that there's a lot of ongoing data initiatives, particularly around COVID and otherwise, to bring data together. Some of that is happening at NIH, some of that is happening out in the private sector. Just wondering what your thoughts are about AHRQ's role in the overall ecosystem of sort of data activities as it relates to healthcare data?
Run as fast as we can and do as much as we can, because you're right, Peter, it is in a rapidly changing environment, and AHRQ would like to be and is working to be part of that. Through Joel and the Data Council in the department, we are part of that through hiring Mamitha as AHRQ's first Chief Data Officer. We're trying to create that broader, not just MEPS and HCUP, but what else can we do? Our focus has been on, and I think we did Joel might have on our last, or one of our last two NAC meetings, talked to you about our data enterprise strategy for the agency and where we're going. But you're right, COVID has accelerated this. It's shown bigger holes. I think the private sector has come together in ways nobody thought could happen. And how do we capitalize that and keep moving forward with that? So the department, we are part of those discussions, and hope, and certainly under Mr. Khanna's leadership, there's not a day that goes by where we don't ask, what more can we do? How can we connect data?
Great, thank you for that. I'll just say, as a member of the NAC, I think that's critically important. I think the role and expertise at AHRQ in terms of interpreting healthcare data is unique and important, and needs to be a part of the overall discussion. So I appreciate that you guys are at the table, and I applaud that. I think that's very important. Thank you.
Well, thank you for bringing that up. And Jamie, I think you wrote in the questions, the discussion is great, and I haven't seen much of it, but that I was wrong. And so I want to admit that and clarify that somebody wrote in and said, and so I'm glad they were listening, that the data, Armando, on that slide was not adjusted. Those were the actual dollars each year. Is that correct, Jamie?
Correct.
Okay, so now I'm correct. Thank you. It's good to correct mistakes. Okay, so yeah. Tina, back to you.
Yes.
How are we doing on time? And
now we're overtime, so it's a little more typical, right? But this is a great conversation, Peter. Your comment is so important, and I'm glad that you brought that up. But let's move on to our next topic, which is also going to be very exciting. So we're going to move on to AHRQ and the COVID-19 update. This will be again David Myers, and we'd like to introduce Mamitha Pancholi.
So thank you, Tina, and thank you everyone else, and definitely a huge thank you to the very large AHRQ team who's made this work possible, led by Bob McNellis and our COVID action team. But let's just share some of this. We have talked with you about this at the last NAC meeting, but we wanted to give you a quick update on what we've been up to, and then a deeper dive into a very exciting new project. Next slide, please. So again, as you know, I like to talk about this in terms of research, improvement, data, and then we're going to talk to you about some new opportunities. So next slide. In research, we told you the last time we had met, we put together in very, very short order some funding opportunities to do health services research in the field to understand how the healthcare system was responding to COVID. And we did two sets of funding opportunities. One looked at teams already in the field, and we are now about to fund or start 15 phenomenal applications that had teams already doing it, that took their question and looked at how is this being changed by COVID. And those include focuses on safety, on patient-centeredness, on system, on learning health system. Those are all launching. They have to have results, meaningful learnings that they share within 3 months. So next winter or early winter, maybe into the early spring, we hope to be learning from those folks. We additionally recognized there were opportunities for deeper dives to learn more about how the health system changed. And we asked those people to focus on quality, on safety, on telehealth, and on disparities. And we're very excited that we will be funding 14 or so 3-year grants. But they also were asked not to wait 3 years to talk about the results, but had to have a plan for sharing what they were learning and disseminating what they were learning, starting within 3 to 6 months of when they were going. So later this spring, those grants, and I'm so sorry we can't already tell you who they are, but they were all, they all know that they're at the just about to be funded moment. So I hope those teams are moving. Additionally, when AHRQ thinks about what we do in research, part of that is pulling research together to help people know what's known and what's not known. Our EPC team created something called Living Rapid Reviews, where they did very, very fast, so not quite as comprehensive, but still quite broad, deep, fast reviews, set up a mechanism so that as necessary, it could be even as soon as 2 weeks when new studies came out, they were able to update the reviews and keep the knowledge up to date. And you can see the different topics that were used. Some of these were used by the Department of Health and Human Services itself, some by external partners such as the American College of Physicians to give guidance to their members. Next slide, please. In practice improvement, we put out a series of how-to guides and things to think about and best practices, interviews with people in the field, trying to make sure that during COVID, that all of what we know about safety and infection control was being used in long-term care, in dentistry. On our topic of diagnostic error, there are a lot of cognitive errors that happen during a pandemic, during a crisis, and how to try to lower those, recognize COVID when you don't expect it, and not say everything is COVID just because COVID is happening, so to get diagnosis correctly, as well as another report on telehealth safety that you can see in there. As well, we recognize that with the explosion of telehealth, that people would want to report on their experience, but we didn't have tools to make that easy, so we have created beta versions that are now publicly available of both the CAP survey and the health plan survey that allow people to report on telehealth visits in a standardized way. And we look forward for those developing in the future. Next slide. Finally, in the area of data and analytics, our team used a lot of our data and other data that they could get their hands on to try to explain what was happening to folks. Some very important work understanding disparities and what might be driving that. Next slide, please. This slide is one of several that AHRQ put out looking at different groups of folks and where they were and their risk of COVID and their employment, because MEPS has such rich data, who were essential workers and non-essential workers with comorbidities, without comorbidities, living with other people that could work at home or not work at home, and showing some of the disparities. This slide itself didn't do it, but one of the ones that really impressed me was some work by our team, Tom Selden and colleagues, that showed that most likely disparities between African Americans and white Americans on COVID outcomes were being driven less by differences in pre-existing comorbidities and more by the social determinants of employment and housing and the ability to self-segregate. So important work to help policymakers move forward. So that's just a taste of some of what we've done in the last 4 months. Next slide. We have 2 new initiatives, one very quickly, recognizing our work with primary care and working with organizations who support primary care practices. There are many, many small and independent primary care practices around the United States that were really struggling during the pandemic. And we've brought together a learning community that's going to meet several times and try to figure out how collectively we can provide support to primary care, moving evidence into practice and getting tools and resources that understanding what their needs are. So bidirectional, that we're doing on a shoestring behind the scenes, but the big work we're doing is called the AHRQ ECHO National Nursing Home COVID Action Network. Next slide, please. So Gopal really wanted us to share with you what this project is, and we're very excited to do that. Next slide. Here's what we're going to quickly try to do to describe the problem, HHS's response, and then I'm going to turn it over to my colleague Mamitha Pancholi, who's really the driving force behind this, to tell you what we're actually doing, and then answer any questions you may have about this project. Next slide. So we recognize why COVID-19 is especially dangerous within nursing homes, people who are vulnerable due to their age, their underlying frailty, and the communal living conditions. Nursing home staff members are also among the most needed and at-risk essential workers. Next slide. The department recognized early on that many nursing homes lacked access to personal protective equipment, to testing, and to having stable staffing. And in response to that, next slide, HHS this summer decided to invest $5 billion from the Provider Relief Fund to provide short-term support to nursing homes with, next slide, specifically giving 2.5 of it directly to over 14,000 nursing homes, focusing on those areas of testing, ensuring that they could purchase adequate PPE, and maintaining their workforce. Next slide. They also said that we're going to have an additional $2 billion for value-based payments for nursing homes who were able to show that they were using the money wisely, were keeping the rates of COVID lower than what was in their community, as well as keeping mortality, even recognizing, so risk adjusted, lower than would have been expected. And those payments started in the fall. The first ones just went out in October, about $250 million that went to almost 10,000 nursing homes who did a really good job in September. Next slide. But even with this, Secretary Azar said, while nursing homes always have the will, they're committed, they're to doing the best thing, they don't always have the knowledge and skills they need. Therefore, next slide, we came in and said, let us help nursing homes implement the best patient safety practices, and developed this thing we're calling the National Nursing Home COVID-19 Action Network. With that, I'll turn it over to you, Mamitha, to tell the rest of the story.
Thank you, David. Next slide. So David nicely laid out the motivation behind this new initiative. So AHRQ, in the past, I would say 60 days, it's been a bit of a sprint, has established the AHRQ ECHO National Nursing Home COVID-19 Action Network, affectionately called the network. It is quite a mouthful. It is a contract with the University of New Mexico's ECHO Institute. And we have also brought in a partner through the Institute for Healthcare Improvement, IHI. We've awarded a $237 million contract for roughly 6 months of work to essentially do certain things. Primary goal here is to provide training and mentorship to as many as 15,000 nursing homes in the country. And it's to increase implementation of evidence-based practices. It's essentially to protect those residents and staff from the COVID-19 infection entering the facility, preventing the spread amongst residents and staff. In addition to that, it's also about thinking about how to reduce social isolation. And that is a big issue with the COVID pandemic. And I think it's particularly true within the nursing home facilities. So we think this is a really impactful initiative. I should footnote this by saying that the participation of these 15,000 nursing homes in the network is purely voluntary. HHS did not make this a mandatory requirement under the Provider Relief Fund or any of the COVID initiatives. We are focused on pairing up the academic medical centers across the country with their local nursing home communities and trying to foster that bridge that we think will serve everyone well long past the end of the pandemic, which is hopefully soon. Next slide. So as I mentioned earlier, so we are leveraging the ECHO Institute, the ECHO model, which, as many of you know, Project ECHO was, we have a long history with Project ECHO. Project ECHO and AHRQ began its journey together back in 2003 with a project on hepatitis C. We revisited that work with them on opioid addiction actually in 2016, and now sort of come full circle and leveraging the ECHO model to help us in this time of crisis. And just as a reminder for those who aren't as familiar with the ECHO model, it is an interactive case-based approach. It's really focused on adult learning And we have designed this to be a weekly session training facilitated by small subject matter experts in quality improvement and infection control. It's very didactic and dynamic and really fosters dialogue amongst the nursing home community itself. Next slide. So this is, again, as I mentioned, a 16-week training course. We've added a mentorship component to it, recognizing that nursing home facilities and the staff and the residents that they serve have unique issues based on their population, their geography, their size. And so we have really focused on small group learning with mentorship from a variety of disciplines and thinking through with our training centers that we've now brought on board, how best to meet the needs of the nursing home community on very specific topic areas related to the mitigation of COVID-19.
So Mammoth, I think we're one slide behind you.
Oh, I'm sorry.
No, it's not you. Could we just get to the next slide?
Sorry, next slide. Apologies.
No. So this is what I think you just explained to folks. So
yes, thank you. Sorry, I need to remind myself to say next slide. Apologies. Next slide. So the curriculum. So we have a 16-week curriculum. It's divided into sort of 2 8-week components, let's say. The curriculum is designed and monitored and updated on a very regular basis. And we owe our colleagues at IHI who have provided an enormous amount of support in developing this curriculum. So the first 8 weeks, it's really focused on prevention and management of COVID-19, testing, screening, and working safely during the pandemic. Next slide. So weeks 9 through 16, we're focusing on managing mild cases, advanced care planning, social isolation, safe care transitions, visitations, reopening, roles of certified nursing assistants, staff well-being, leadership, and communications. And again, these 16-week sessions developed by IHI are actually dynamic in nature. While these sessions are sort of laid out in a nice curriculum, we are updating them constantly and taking the feedback from our nursing homes on a weekly basis. Next slide. So here's a nice map. I know folks have been looking at a lot of maps lately. But this one is focused on our current status of network training centers across the country. And as of November 6th, which is where this slide came from, we have now 69 training centers. Our goals for next week is around 80. I think we're actually, as of this week, about at the 80 mark, thankfully. And I want to also just give a shout out to some of our colleagues on the NAC, whose organizations actually are part of our network. So MedStar, Stanford, and a few other, Agent Street, I think, is also one of them, and several others as well. And so we thank you for that. We couldn't do this without our training centers. Next slide. So just a quick status report on where we are in engaging nursing homes and how many cohorts we've launched. So as of November 6th, we've had over 54 cohorts launched. Now, a cohort is roughly, I would say 24 to 35 nursing homes in a cohort. That varies based on by the state and the community. Our goal for next week is to get to 100. I think we are well on our way on being able to do that. Actually, I should say this week. This week will be Friday, November 13th. We've also had around 1,200 or so as of last week that actually received the training, nursing homes, that is. And our goal for this week by Friday is that we'd have 2,500, though I think we are on track at this point to get closer to 3,000. And where we are now is really thinking about how best to get the word out there. We are heavily in active recruitment of nursing homes to make them aware of the opportunity. We're collaborating with CMS and with CDC, again, through their venues to get the word out that this training opportunity exists. And we are hopefully, with all of that activity, able to bring on board several thousand more nursing homes as well. Next slide. So while all of that is happening under the University of New Mexico's umbrella with AHRQ, Echo Institute, and that we are also thinking about how we're going to be engaging our national stakeholders and coordination across our federal agencies. There's a lot of work happening in the nursing home COVID-19 space. There's a lot of other questions and other needs that need to be addressed. We want to make sure that we're not duplicative. So we're leveraging our existing relationships within the community, within the department, and will be very shortly utilizing our some new mechanisms to be able to develop some new tools and resources, and to really have a more focused communication dissemination strategy to get the word out about this work and trying to also make this work available to those nursing homes that may not have joined the network. And so we're hoping that this work will also live beyond the next several months of the pandemic, that there's real value in disseminating that the tools that we're building for this network, that there's quality improvement work that we can also leverage. And so we're really trying to think about this as a broader opportunity to get to that nursing home community more long-term. Next slide. So questions and discussions. Let me just pause and just give a great shout out to my colleagues, both in the department, across CDC, CMS, and particularly at AHRQ. I mean, this was probably the fastest sprint I've ever done in government. We did a lot of work in 60 days. We stood up, an 80 training center network and reached several thousand nursing homes in the span of 60 days. And we are full force, full throttle for the next several months to make sure that we are as impactful as we can. And so I just wanted to thank my colleagues at AHRQ, David, and others for the opportunity to do this. So I'll pause there for questions.
Great, thank you so much. It's been, that was really informative, and we have some questions coming in. I would like to just, I want to mention that I got together with a couple of the other NAC members and put together a blog on telemedicine recently. And I think this is a great opportunity. There's so many great ideas here. So I really encourage other NAC members to, if you're interested in some of these topics and you feel like there's something you can write in a blog, this is a great opportunity to put on your NAC hat and really disseminate the message that we're hearing about. And so just something to keep in mind. And then we have some questions coming in. We'd love to hear from all NAC members. So please send your questions. We have one from Asaf Bitton. Please, can you unmute yourself and ask your question?
Thanks so much. And this is fantastic work. I've heard a little bit about it from various folks in the network. And I just I was looking at the goals slide, number 43, and I just wondered if you could share a little bit more about, for such a large collaborative and important expansive works, and I think this might touch also on Edmondo's question, what are some of the core shared process and outcome measures that you're using to evaluate the impact in this rapid implementation cycle? Thank you.
So great question. So there's a couple of challenges that we're trying to sort of overcome. So we are collecting feedback from the nursing homes themselves. So in terms of understanding whether the training that we're providing, the curriculum, is useful to them, that we've got, I think, fairly well covered. It's a little trickier when you're trying to think about outcome measures and looking at the direct connection between whether or not you saw infection rates go down or mortality rates go down. So that is a softer connection. And so we will be looking at, in the next couple of weeks, actually, trying to identify mechanisms and sources of data to be able to look at that. So we are in discussion with CDC and thinking about how we can use the national nurse, the NHSN, sorry, I always get that one wrong. We're also working with CMS and trying to get their data as well so that we can then do sort of basically an evaluation or quantitative assessment to see what that looks like. But I will admit, we're not doing a primary data collection of those nursing homes to look at, whether, what their current infection rates were and whether or not they decreased over time.
One super brief, thought I had wondering, and I totally get that and wouldn't expect that you'd be able to do that. But, I think that one of the things that's emerging in this area, and one area you could ask the nursing homes to consider measuring is our different wonderful measures of safety culture. I think what we've all seen is that, you have the core workforce of nursing homes, and then you have the temporary workforce of nursing homes, and then you have private duty workforce. And those sort of concentric, non-overlapping rings of key staff that care for patients makes it really hard to implement and push forward safety culture. And so any work that's building safety culture, that's translating and bisecting across those concentric rings, I think can move well toward our shared goals. Thanks.
Thank you for that. Yes, we will take that into account. We are literally in the process of, I would say, designing an assessment / evaluation, although it's probably not in the traditional sense. We are somewhat limited by, all of the hurdles one has to cross in order to do primary data collection. But I think what you suggest is a good point. Thank you for that. Any other questions?
Okay, we have a couple more questions. Susan?
Okay.
Yes, thank you. I was just wondering about a couple of things. One is, how much funding are the nursing homes getting to do the work that they are going to be asked to do? And just another thought is that, given, and I think just what Asaf just mentioned and what we all know about the relationship between culture and outcomes and patient experience and other important metrics, whether we've thought about using the survey of patient safety culture in the participating nursing homes as another tool to guide the important transformation work they're doing.
So the first question. So yes,
Yeah.
So under the Provider Relief Fund, we have the ability to compensate the nursing homes. So we are planning. And this is a very small amount of money. It's nominal, and we recognize that. It's about $6,000 per nursing home, and it's really just was calculated based on compensating the nursing home for staff to participate in the actual training. We recognize that that's nowhere near enough, but it's just enough to hopefully compensate them for time. And the assumption here is that, again, the Provider Relief Fund is also accessible to them. So each nursing home, once they attest to the criteria, are able to go ahead and submit for a larger amounts of money through the Provider Relief Fund directly. Part to your second question. So yes, we would love to absolutely field our own safety tool, our safety questionnaire. That would be a wonderful opportunity. There are, again, that would be considered a primary data collection, which we have thought about doing. It's a much bigger lift. I think it is something that we have put into our idea wish list of sorts. It does become a budget question, and I think as we go forward in the next fiscal year, that might be one of the things that we actually submit for and think about. How can we learn from this experience? And thinking about culture and safety in this context at this point in time is absolutely important. Absolutely.
Yeah. Thank you.
Okay. Yeah, I'm going to try and get to all of these questions. So